a great elaboration on diabetes and also pre-diabetes. Uh, for great information on this developing, we can have new guidelines. We'll have discussion at the end of this session. So please, sir, be seated till that.
Yes, sure.
Speakers, please invite our chairpersons. Please invite our next speaker.
Yes. So we are really fortunate to have with us Professor Rakesh Sahay, who is professor and head of endocrinology at Osmania Medical College, and also sir is consultant endocrinologist at Sahai's Endocrine and Diabetes Center, Amarpet, Hyderabad. Sir is currently president of Endocrine Society of India and also vice president of South Asian Federation of Endocrine Societies. Sir has been section editor, Tropical Endocrinology and Endotext, which is an online textbook of endocrinology. Sir is also an editorial board member of IJEM, and Sir is National Executive Committee member of RSSDI and has organized RSSDI National Conference in 2016. Sir have also received several awards, including National Academy Fellowship Award of Medical Sciences in 2021, Fellowship of American College of Endocrinology in 2009, Fellow of RSSDI in 2015, and FICP in 2006, FIACM in 2008, and Sir has been awarded as Best Teacher in Medicine by Government of Telangana for 2018 on the Teachers' Day. Sir has 150 publications in various national and international journals, and he has also authored chapters in various textbooks and monograms on diabetes and endocrinology. We welcome you, sir. We are really fortunate to have you, and the stage is all yours.
Thank you. Thank you, Dr. Ashish, for the kind words of introduction. Thanks to the organizers, particularly Dr. Bansi Sabu and his entire team at Diacon for inviting me, and a big congratulations to him for organizing such a wonderful program. So I'll be speaking in the next 15 minutes or so about steroid-induced diabetes and the management of steroid-induced diabetes. So let me share my screen. Is my screen visible?
Yes, sir, it's visible.
Yeah, thank you. So what I'll try to do in the next few minutes or so is discuss about the physiological role of steroids, the various steroid preparations, and the magnitude of the problem of steroid-induced hyperglycemia, the mechanisms that are involved, and particularly and the management algorithms and how we should go about with the management. So steroids basically were introduced in about more than 70 years back, and in 1950 the Nobel Prize in Physiology was jointly awarded to Edward Calvin Kendall, Richardson, and Philip Schwarzer, and they were they were credited with discovering the steroids, and that has actually brought about a revolutionary change in the management of many disorders. As we know, steroids are used not only for replacement in adrenal insufficiency, but also for mainly for the anti-inflammatory effects, and also for hemodynamic stability. So a lot of conditions, as you can see the list, whether you look at any sort of organ disorder, or any specialist will be using steroids for management of many conditions. And so therefore it's important that we understand that steroids, what they do to hyperglycemia, and how they bring about hyperglycemia, and what we should do about managing such a problem. So if you look at the mainly how the steroids work, they bind to receptors present in the cytoplasm, and then this steroid receptor complex goes into the nucleus, and there they bring about through various mechanisms, they activate the production of the synthesis of various proteins, which may have effects on inflammation and many other processes in the body. and this actually lists out that the various proteins which are regulated by steroids have an effect on the immune functions and metabolic functions also. As you can see, PPAR gamma, tyrosine, aminotransferase, and PPCK, glucose 6 phosphatase. These are the ones which actually have an impact on glucose metabolism. Then there are other effects on bone and other endocrine conditions. And in the net effect that we see clinically, what we see is that steroids cause increase in blood sugar. They reduce inflammation, retain sodium in the body, regulate metabolism through various of these processes that we have seen. They reduce calcium absorption and also reduce immunity. So the myriad effects of steroids are seen, and therefore there are a lot of side effects which became quite obvious right from the time steroids are introduced. The side effects became very soon known, and despite the side effects, the steroids remain crucial and life-saving medications, and because they have several anti-inflammatory effects. Coming to the role of steroids in causing dysglycemia, if you look at the overall use of steroids, we can say 0.9% of general population may be using corticosteroids for some reason or the other, and we see that the highest usage is in older ages, and nearly 1/4 of those who consume steroids do it for more than 6 months. This is data from the usage of medications, and what we see is that steroid-induced hyperglycemia may precipitate the appearance of they cause a lot of effects, precipitating the diabetes, or it may be and non-diabetic individuals may normalize the blood glucose levels once steroids are stopped, but there are many individuals in whom it may precipitate the development of diabetes. And if you look at the incidence of hyperglycemia after the use of steroids, it's said that it is seen that more than 50% of those who use steroids develop blood glucose levels more than 200 milligram per dl, and up to 40% of patients with pre-diabetes. I mean, the condition they used is neuropathy without a glycemic disorder. This is probably a pre-diabetes or dysglycememia. Almost 40% of them developed diabetes after taking steroids. Patients with respiratory disorders also have a high occurrence of dysglycemia after steroid use, and also particularly those undergoing organ transplantation. So steroid induced hyperglycemia can be, those patients who have aggravation of hyperglycemia with pre-existing diabetes, those in whom diabetes is unmasked by the steroids, that is, they were having some pre-diabetes or some other dysglycemia earlier, and the use of steroids unmasked their diabetes. And then there could be another category of patients where the appearance of they have the glucose corticoid induced diabetes is precipitated by the use of steroids. So these are the three broad categories we could say of people who use steroids. And so we can see that it can precipitate the new onset of diabetes. More than 2/3 of patients who develop hyperglycemia develop it within 1 to 2 days of using steroids. So very soon after starting steroids, this happens. So we should be vigilant of monitoring glucose levels right from the time the steroids are started, so that we can identify the hyperglycemia which occurs. Otherwise, many times this is not done, and people are identify hyperglycemia many days after starting steroids, and during that period the person is at high risk of problems because of the hyperglycemia. So, and the predominant problem that is there is postprandial hyperglycemia. So majority of people have postprandial hyperglycemia. So just doing the fasting may underestimate the incidence of hyperglycemia. So, and then the pattern of excursion, however, depends upon the type of glucocorticoid that is used, its dose and regime. And replacement doses, when steroids are used in small doses, like replacement doses 7.5 to milligrams or lower, it may not cause so much of hyperglycemia. Those with moderate doses like 7.5 to 30 milligrams may have higher incidence, and those with more than 30 milligrams per day very certainly very often go on to develop hyperglycemia. So the predictors of new onset diabetes with steroid use could be listed as the dose and duration of steroid treatment, the age of the patient. Older ages more likely, higher, those who are obese are more likely, previous glucose intolerance, and those who have demonstrated some degree of insulin resistance, those who had a family history, and particularly some leukocyte antigens are HLA types, particularly those who undergo transplant, who have HLA typing. Some of the HLA typings are predisposing to the development of steroid induced diabetes. diabetes. Gender may not play important role, and early withdrawal of corticosteroids, whatever the reason for which we use, early withdrawal is good in terms of preventing the or bringing down the glucose levels to normal. So this again lists out the risk factors: presence of hypertension, presence of those who are smoking, those are more likely; those who have got impaired renal function, and those who have got specific single nucleotide polymorphisms are also at risk. So these are all the risk factors that are there, and the important issue is that if you why do we need to screen patients for steroid-induced hyperglycemia? It's important because the problem of hyperglycemia itself, because of the problem, the high prevalence of hyperglycemia itself, which may prolong the hospital stay, which may worsen the outcomes. Secondly, steroids increase the risk of infections, and so these are the major effects. And control of hyperglycemia in any situation, because we have got studies which have shown that when you look at patients hospitalized for various reasons and look at hyperglycemia, those with transient hyperglycemia, even new onset hyperglycemia or transient hyperglycemia, the correction of hyperglycemia is very important in such situations. So even for steroid-induced hyperglycemia, correction of hyperglycemia is more important than worrying about whether they are going to develop diabetes or not. It is important that we correct the hyperglycemia, manage the hyperglycemia effectively, and that is going to improve the outcomes. So just to show you the mechanisms, what is happening, steroids have multiple reasons. They through their actions at the on the protein synthesis, they decrease protein synthesis, increase protein degradation, and they also decrease the glycogen synthesis. And in the liver, what happens is they increase the activity of this PCP, phosphoenol pyruvate kinase, carboxy kinase, which is an important enzyme regulating gluconeogenesis, that is upregulated in the liver, increasing gluconeogenesis. It is downregulated.
Is it network issue?
In the adipocyte. Excuse me, am I audible? Yeah. So I think this is the contrast that happens in the liver. There is an increase in activity of this gluconeogenesis. In the muscle, in the adipocyte, the PCP kinase is reduced, and because of this, what happens is that there is increased free fatty acid available, which is going into gluconeogenesis in the liver. So the various mechanisms are listed here, but suffices to say that there is increased insulin resistance and decreased insulin secretion from the beta cells in the pancreas through different mechanisms, which are causing the hyperglycemia in people who are on steroids. Now it's important to understand what is the type of steroids they're taking. Short acting steroids have a different effect. Intermediate acting steroids have different effects. So these are the intermediate acting steroids, and long acting steroids like dexamethasone and all that have a different pattern of hyperglycemia, which is shown here. So the short acting ones, like they have an onset of hyperglycemia within 1 hour, peaks at 3 hours, and resolves in 6 hours. So just like as you can see, we are familiar to seeing the insulin profiles, the action profiles of insulin. So similarly, you see with short acting steroids, this is the type of hyperglycemia that is produced, type of glucose profile that is produced. With intermediate acting steroids like prednisolone and methylprednisolone, this is the type of glucose profile produced, peak in glucose levels at 8 hours, and a resolution in 12 to 16 hours. And long acting steroids have a longer duration of action, like this, longer duration of hyperglycemia. So it's important, as you can see, all of us can understand that for this type of steroid, a short acting insulin would be very good. For this type of steroid, insulin like NPH will be very good, which has a 12 to 14 hour action, while for these a longer acting basal analog like glargine or degludec would be good for this type of steroid use. So clearly understanding this is important, because we can understand what type of insulin is going to be particularly useful for managing such hyperglycemia. Now, important that when a patient is admitted and started on steroids, you need to monitor the CBG levels, the capillary blood glucose levels consistently. If they are consistently below 180, you may stop testing. But if they are going beyond 200, then you need to start treatment. In known cases of diabetes, if the CBG is more than 200, then testing should be increased to more than 3 times per day, and treatment should be intensified accordingly. For those who are not having, and those who are on a single dose of prednisolone, as we've seen, that's an intermediate acting steroid, and it best is treated with NPH, which could be given in the morning, and intermediate acting NPH at the same time as a steroid injection may be the best form to manage hyperglycemia in people who are on prednisolone. And this is the commonest type of steroid that is used in most of patients who are using it for anti-inflammatory purposes. For those who are on, so you can actually calculate the dose also. For those who are on prednisolone or methylprednisolone, as I said, once a day, use NPH 0.5 units per milligram of glucocorticoid that is used, and give it along with the glucocorticoid in the morning. For those who are using more than 2 times per day, maybe you require a little higher dose, but you may need to give it twice daily again. You may need to give it twice daily, same dose, 0.5 unit per milligram of glucocorticoid. It may range from 0.25 to 1 unit, but averages, this is what you can start with. And when you're using longer acting steroids like dexamethasone, if you're using NPH, then you require larger doses of NPH, or you may prefer to use any of the the newer basal analogs which have a longer duration of action. When you're looking at hydrocortisone, if you're trying to use NPH, you require smaller doses of NPH. Whether you use it OD or BD, you require smaller doses of NPH given along with the steroid. Now, when you are looking at patients who are on multiple dose hydrocortisone, you need to use appropriate therapy with MDI regime, maybe the treatment of choice, or you may be given, you can sometimes use premixed also, but most important is most suitable is a basal bolus regime in such patients. Now, if a patient is on basal insulin, consider switching to the morning administration and increasing dose of by 2 to 4 units increments every 24 to 48 hours, particularly in those who are getting this methyl pulse therapy. In such patients, it may be good to give this basal insulin in the morning. And sometimes when there is persistent hyperglycemia, you may switch to IV insulin infusion for a short duration of time. Then once you have an estimation of the total daily dose, then you can switch back to basal bolus therapy. Now, this is again this is the chart showing all the different insulins and where they're particularly useful. They're particularly useful. You can use NPH particularly for a short-acting, intermediate-acting glucocorticoid. Prandial bolus insulins for short-acting glucocorticoids. Basal bolus therapy is used in very severe hyperglycemia, not particularly for any particular type of glucocorticoid, but when there is severe hyperglycemia. So this is how you could decide what type of insulin to be used depending on the type of steroid that is being used. But important thing is that don't use sliding scale, because this is going to cause confusion. You need to use basal insulin and appropriate doses of bolus insulin depending on the steroid that is being used, and that is going to the dose of steroid that is being used, and for the duration of time that it is being used. Once it is being tapered, we'll just discuss about that a little later. Now, coming to the management with OADs, sometimes you may be able to manage with OADs also when you have a patient who has been quite stable, who doesn't have very significant hyperglycemia, who are not on non-insulin therapy earlier also. There you can see that short-acting sulfonylurea like glyclazide is a very good agent which matches the action profile of this prednisolone, just like we were speaking about NPH. Glyclazide here matches that action profile, and you can say that for every 5 milligram of prednisolone, you may use 40 milligram of glyclazide could be matching the requirement for about 5 milligrams of prednisolone. If patients are so this is how you would do it. Maximum is one time dosing is good enough. You can go up to a maximum of 240 milligrams before breakfast. So that's the usual tendency that you may use for controlling oral anti-diabetic agents. Intermediate acting insulins may be added in addition if required, if they are not controlled on OADs. And hyperglycemia, if it continues in the late evening or overnight, adding insulin may be particularly useful. Now, current evidence, there's not much of evidence. This is the RSSJ guideline which I'm quoting here. This was brought out in 2016-17. So there was not much of evidence available on GLP-1 RA or SGLT2 inhibitor. So they did not speak about these agents. But if you look at the recent evidence, recent data that has come out from the COVID time, when a lot of steroid-induced hyperglycemia was being managed, people have used used different agents like SGLT2 inhibitors have been used in some scenarios in patients who are stable. Some of the studies we have seen where dapagliflozin was used, the DARE 19 study and other studies have shown that there was no problem with the use of these agents, but they had their limitations, and they could be used in some of the stable patients. Metformin was also found to be a good agent in some of these patients. So I think and particularly the DPP4 inhibitors were particularly found to be particularly effective in some of these studies. The target glucose level should be maintained between 140 to 180 for majority of the patients. Even in the ICU, you would look at maintaining between 140 to 180 being the ideal. In the wards, you may look at a preprandial level of less than 140 and a postprandial level of less than 180. So this should be the target. And when you're tapering the steroids, you should see that the dose of anti-hyperglycemic agents need to be tapered accordingly. A weekly reduction of dose of 5 milligrams of prednisolone requires a reduction in the total dose of insulin by about 20 to 25% reduction, or a dose reduction of glycoside. If you have been using glycoside, you can reduce it by 40 milligrams every time you bring down the dose. And normoglycemia can be observed in many patients after stopping the steroids, but however we should follow them up and see that we retest after 12 weeks to see that the patient is back to normal, because they could still continue to have hyperglycemia. Important thing is to reassure and reinforce to the patients, educate them, and see that they screen again, because this chart shows that, tells us how we should go about with in terms of people who have known diabetics. You look at titrating the dose of drugs or insulin rapidly. Once you are reducing the dose of steroids and stopping them, encourage see that they are educated about this and they are monitoring frequently. For those who are not diabetics, who become normal, whose blood glucose levels become normal after stopping steroids, you should still test them after 12 weeks to assess whether their hyperglycemia is persisting or not, and they should be educated about subsequent testing. Maybe every 6 months they could be testing so as to ensure that they're maintaining normoglycemia. So it's important. I would like to conclude by saying that it's very important when we are using steroids to see that we follow use it for a clear indication, use the appropriate dose for the appropriate period of time, because there are several adverse effects of steroids, hyperglycemia being one of them. And it is important that we as diabetologists, endocrinologists and physicians who are managing people with hyperglycemia should understand the type of steroid that is used and match it with the appropriate therapy, and see that we are effectively maintaining the glucose levels of our patients in the normal range. Thank you all for the patient hearing. I would be happy to answer any questions later.